guys. All right, so week 10, we're going to be talking about the spine and also posture. So this week, we're going to have a look at the ligaments of the spine. We already went over them back in structural anatomy, but we're going to revisit them today. We're going to talk about our range of motion at different sections and different areas of the spinal column. We're going to have a look at our posture, so the normal curvature of the spine and what that looks like and what it looks like if it's out of whack, and how that might influence the load and the stress going through our spinal column. So first off, like I said, let's have a look at the ligaments of the spine. Now, when we're talking about the spinal column, here we go. The first thing that we need to know is all the different sections, the names of the bones, and so on. Now, I'm not going to cover that for you here. You should already know it, but we need to know the names of some of the landmarks to be able to name the ligaments of the spine as well. So let's go through these quickly and talk about some of the important features of these ligaments of the spine. So if you can remember way back to structural anatomy, the first big ligament of the spinal column running down the anterior portion of the spine. So remember, the bodies are on the anterior portion. So if this was a person, they'd be looking off in this direction. And then this is the back, the posterior side. So down the anterior side of the body of the vertebrae, we have our anterior longitudinal ligament. This one runs all the way down the front of the bodies. Now, we know that our ligaments, they work when they get pulled tight. So if you think about different actions of the spine, what action is going to pull this anterior ligament tight? It is going to be hyperextension, right? So the anterior longitudinal ligament works to limit hyperextension of the spinal column. Now, if we have an anterior longitudinal ligament, that means we're also going to have a posterior longitudinal ligament. So if you have a look at the slides now, we can label our anterior longitudinal ligament. And then our posterior longitudinal ligament travels down the posterior side of the body. So it's tough to see it on this model here, but you can see it clearly in your lab books running down the posterior side of the body. And anything behind the center of the bodies of the vertebrae is going to get stretched or get pulled tightly when I flex my spine or when I bend over forwards at the trunk. So anything behind the center of the vertebrae is going to pull tight and work during flexion of the spine. Okay, then the next ligament we can have a look at is the interspinous ligament. So this ligament runs in between spinous processes of the adjacent vertebrae. So spinous processes being these pointy things sticking out the back here. The interspinous ligament runs in between those. And then we also have a supraspinous ligament which runs along the tips of those spinous processes. And again, both of these ligaments, the interspinous and the supraspinous, are going to get pulled tight and work to limit excessive flexion of the spinal column. Great. Now, the next ligament I want to talk to you about is the ligamentum flavum. You might remember this one from structural. It's the one with the funny name, ligamentum flavum. And this ligament actually runs in between the lamina of the adjacent vertebrae. So the lamina just being the part of the vertebrae between the transverse process and the spinous process. So running in between those features there, as one on each side, of course. So we've also got one running down here. Now, ligamentum flavum is a funny ligament, and that word flavum actually means yellow. So ligamentum flavum, it's called the yellow ligament, and it's actually the color yellow. So if you were to do a dissection and have a look at it, you'd see that this ligamentum flavum is a yellow color. Now, the reason for the yellow coloration is because it's not made up of the same ratio of components as is the other ligaments. So all ligaments in the body are made up of different proteins, mainly including the collagen and the elastin fibers. Now, most ligaments have more collagen than they do elastin. So in all the other ligaments we've spoken about, they've got more collagen. Whereas in the ligamentum flavum, it's actually got more elastin through it. So it's at a 2-to-1 ratio. So there's 2 elastin proteins for every 1 collagen protein. That means that it's going to look a different color, but it's also going to have different properties. So because it's got more elastin, we can think about it as being more elastic. So elastin is a protein that provides those elastic properties to whatever it's in. So we've got collagen and elastin in our skin as well. So you might have heard of collagen before being the protein that stops you from getting wrinkles. Elastin is sort of the same. They both work similarly, but elastin, I like to think of it as the spring back of your skin. So if I pinch up the skin on my hand here, so I'm displacing it now, and then it's gonna spring back. That's showing that, thank God, I have a little bit of elastin left in my skin, because at some point I'm going to get to an age where I'm not going to be able to do this demonstration anymore, and every year it's like a bit of a surprise as to whether it works. So elastin, think about it like this. It's that popping back of the skin back into that normal position. So this ligamentum flavum, it's behind the center of the vertebral bodies, right? So it's going to get pulled tight during flexion, okay? And then when we stand back up, so if we flex our spine, if we bend over, so you're going to bend over to pick something up off the ground, that ligamentum flavum is going to get stretched. And think of it like an elastic band, right? So you're stretching the elastic band as you bend over. And then when you stand back up, that elastic band's going to pop back together. So it actually provides some help as we extend our spine up and stand back up. So it works almost like a little muscle, helping with the extension of the vertebrae. So if we're flexed and we're bent over, as we stand up, that ligamentum flavum is going to contract together like that elastic band and help us come back into neutral. Obviously, of course, there's the big muscles, the erectus spinae, doing that as well. But that ligamentum flavum is also giving a little bit of help as we extend our spine and stand back up. So it's a very important ligament. It's also the deepest ligament of the spinal column. So if you go to get a needle in your spine, so whether that's like you're getting a spinal tap or perhaps an epidural, I've heard doctors say that when they put the needle in the spinal column, when they put it through all of the tissue, the ligamentum flavum is the last thing that they go through before they get into that spinal column and get into the dura mater and all of those different layers of the spinal column. So often they say they can feel like a little bit of resistance when you get to this ligamentum flavum, because it's sort of like an elastic band. So they're pushing the needle through, then they get to this like little bit of resistance here, and then poof, the needle goes through. So the ligamentum flavum is a deep thing, and you can feel the needle go through it as you put it into someone's back. I don't know what it feels like. I am not planning on putting any needles into anyone's spine anytime soon, but apparently that's what happens. So ligamentum flavum there, interesting ligament, it's yellow in color. Okay, and then we have our last ligament, the intertransverse ligament. Now, this ligament runs in between the transverse processes of the vertebrae, so again on both sides. So it's going to get pulled tight as we laterally flex our spine. So if I'm moving side to side, that's me laterally flexing my spine there. So in the next little activity, you're asked to sort of talk about which ligaments bear the greatest strain during the different motions of the trunk there. So in hyperextension, if we extend the spine back, we know it's going to be a ligament that's running in front of that center point of the bodies of the vertebrae, so it's going to be the anterior longitudinal ligament. which bears the greatest strain during that motion. So whilst it's saying bears the greatest strain, really this question means which ligament is getting pulled tight in this action. The next one is flexion, so bending my spine forwards. Now there's quite a few different ligaments that get pulled tight during flexion of the spine. There's the posterior longitudinal ligament, the ligamentum flavum, the intertransverse ligament, the interspinous ligament, and also the supraspinous. So out of those four, which one is bearing the greatest load? Which one is really helping to limit that motion? And it might not be the one that you're thinking of. Most people are probably thinking of the supraspinous, right? Because that's the most posterior, so you think that's probably getting stretched the most. Well, actually, it is the interspinous ligament. So the interspinous ligament in between the spinous processes is bearing the greatest strain during flexion of the trunk. Then we have lateral flexion. So I said before that the ligaments that work during lateral flexion of the trunk are our intertransverse ligaments. But the important thing to remember is that it's the contralateral intertransverse ligament. So what that means, that word contralateral, is that if I laterally flex my trunk to the right-hand side, to this side, it's going to be the ligaments on the opposite side that get pulled tighter, right? So if I laterally flex the trunk this way, it's going to be the opposite intertransverse ligaments that get pulled tighter. These ones aren't getting pulled tight, these ones are getting compressed together, so they're not doing anything at all on this side. So it's the opposite intertransverse ligament. And if we went the other way, so if I bend or laterally flex my spine to this side, it's going to be these intertransverse ligaments that are going to bear that strain during that motion. And then finally, rotation. So we haven't really spoken about this so far. Rotation of the trunk is just me twisting my trunk around. And it's actually a ligament that we haven't spoken about up until now. It's the ligaments that surround the capsules of the zygapophyseal joints, or the facet joints of the vertebrae. So we know where each vertebrae meets right here, as you can see there. It's where that superior articulating facet meets the inferior articulating facet of the adjacent vertebrae, and this joint is called the zygapophyseal joint, or some people call it the facet joints of the vertebral column. Now during rotation, you can see that there's a lot of movement going on at these facet joints. So as I rotate my spine, you can see those two move off the top of each other. As I rotate my spine, it's the ligaments that surround the capsule of this zygapophyseal joint. Now we don't have to name them, we just call them the capsular ligaments of the zygapophyseal or facet joints. All right, that's perfect. Okay, so great, that's ligaments of the spine. Now something important I also want to mention when we're talking about the spine is you can see in the image in the slides right now, right at the bottom of the slide, it has anterior portion and posterior portion of the spinal column. So the anterior portion really is our vertebral bodies, and then the posterior portion is our spinous processes, our facet joints or zygapophyseal joints, and so on. Now, something I want you to make a note of is that it's the anterior portion of the spinal column that bears the compressive loads of the spine. So all of the loads of the spine, or most of them, are going through these big bony bodies of the vertebrae and also the intervertebral discs. And then it's the posterior portion that guides the movements of the spine. We're going to talk about that now. So the posterior portion guides the movements, and specifically it's actually the shape of the facets or the shape of those zygapophyseal joints that guides the different movements of the spine. So let's have a look now at the different movements of the spinal column and which areas of the spine really allow for these different actions. So We've got 3 columns here. The first one is looking at flexion and extension. The next one is looking at lateral flexion. And then we have rotation of the trunk. So these are the 3 sort of different axes that our trunk moves on. So we can flex and extend. Bending forwards is flexion. Standing up straight is extension. We can laterally flex, moving side to side. And then we can rotate our trunk around as well. So we can see on the y-axis all of the different joints of the spinal column, so all of the vertebrae there, from the occipital bone, which is OC, to C1, to C2, to C3, and so on, all the way down through the thoracic and through the lumbar as well. Now, the black lines show how much range each of these joints allows in that action. So if we look specifically at the first joint in this figure, so OC to C1, the joint at the very top of our neck between our very first cervical vertebrae being the axis and, or not being the axis, being the atlas. So the joint between the atlas and the occipital bone, right at the base of our skull. Now this joint allows for flexion and extension and lateral flexion, but absolutely no rotation is taking place here. So you can write that down on the bottom of your page as well for occipital joint to C1. A little bit of flexion and extension, a little bit of lateral flexion, but 0 rotation at all. Then for C1 to C2, now this is our atlas meeting our axis, also called the atlantoaxial joint. And if you can think back to structural anatomy, this atlantoaxial joint is that joint between the dens of the axis and then the atlas. So it's that pivot joint between those 2 bones there, made that pivot by having the dens, right? So if we look at that, we can see that there is some flexion and extension allowed at this joint. There's no lateral rotation whatsoever, and then there's heaps of rotation, because of that pivot joint. So heaps and heaps and heaps of rotation there. I can also get some flexion and extension. Awesome. And you can see that line through the rotation line just represents how much rotation there is happening there, because 47, it means it's not to scale anymore, basically. So that dash going through that black line means that we're not looking at it to scale. And if it was to scale, that line would extend out a lot further, up to 47. Okay, then we have C2 to C7. So this is looking at the rest of our cervical vertebrae, so the rest of our neck, really. If we're thinking about our whole neck, what actions we can do there. And we can see that there is a good amount of flexion and extension. So if you flex and extend your neck right now, yeah, there's a good amount of range there coming from just the neck area. There's a good amount of lateral flexion too. So let's see, can we laterally flex our neck? Yeah, I can get a good amount of lateral flexion there as well. And then rotation, again, good amount of rotation. So now I'm not thinking about like the pivot joint that allows my head to rotate, but I'm thinking specifically about rotation of the neck itself, right? And I can still get quite a good amount of range through that cervical vertebrae. Then for the thoracic, so the thoracic T1 to T12. Now, I said before we turned over to this page that it's the shape of our facets that really allow for different actions at the vertebral column, and this is where this really comes into play. So if we think about the facets of the thoracic vertebrae, this is like back in week 1 structural anatomy. So we learned that the facets of the thoracic vertebrae face front and back like this. This is how the facets of the thoracic vertebrae face, and then the lumbar vertebrae, they face like this, back and forth, towards each other. So thoracic facets are in the frontal plane, whereas lumbar facets are in the sagittal plane. So if the thoracic facets are in the frontal plane, that means that the thoracic vertebrae is going to be good at frontal plane movements. And we can have a look and see on our table that we're right. So frontal movements of the trunk would be our lateral flexion, and there's also rotation there as well. So we can see that the thoracic vertebrae is actually not good at all at flexion and extension. So flexion and extension occurs in the sagittal plane. Lateral flexion occurs in the frontal plane. Thoracic facets are in the frontal plane, so we can assume that our thoracic vertebrae is going to get good range through lateral flexion, and it does. And then also rotation. And then finally, for the lumbar, I said that the lumbar facets are in the sagittal plane, and sagittal plane movements are flexion and extension, and we can see there straight away that the lumbar vertebrae are very good at getting range through flexion and extension. So when I bend my trunk over, if I go down to pick something up off the floor, that flexion and extension is mainly coming from that lumbar spine. And if you think about it, whenever you see someone who has injured themselves by not picking up something from the ground with a flat back, you know how they always say if you're going to pick up something heavy, you need to do it with a flat back, make sure your back's not rounded. And if they do round their back and they do hurt their back, it's always the lower back. It's always the lumbar vertebrae, right? And that's because those lumbar vertebrae are the vertebrae that are involved in flexion and extension and bending our back forwards and back. Okay, so now let's have a look at the curves of the spine. So we know that our spine is not a straight structure. It has curves in it, which allow for some shock absorption there as well. And the curves sort of go convex and concave, so they're not all. It's not all curved in one exact way. It's like an S shape almost. So in this little part of the lab book, what we can do is actually measure the angles of those curves of the spine. So we learned back in structural anatomy about lordosis and kyphosis. So kyphosis being that real hunchback action through the thoracic spine. So thoracic spine comes forwards. And then lordosis being that really exaggerated lumbar curve. So how do we know if we have this kyphosis or this lordosis? Well, we can measure the angle of these curves here. And I'm going to show you how to do that quickly in this video. So have a quick look and you can follow along and do it in your lab book at the same time. Okay, so we're not going to worry about having a look at the cervical vertebrae. We're just interested in the thoracic and the lumbar, so you can cross out the cervical one for the purpose of this lab. So what you're going to do here is grab a ruler and line up those lines of the thoracic vertebrae until they intersect with each other, and then that's the angle that you're going to measure there. So once those lines intersect, that's the angle that I'm interested in here, and I'm going to take my protractor and measure this angle in just a moment. So firstly, we'll also draw the lines for the lumbar. Now, important thing to note here is that the lumbar lines actually intercept in the opposite direction, and that's because the curves are in the opposite formation, so they intercept differently. So this is how we draw our two different angles on, and then we can take our protractor and measure those angles. So let's see what I come up with. Okay, so we got about 38 degrees for the thoracic spine and then 40 degrees for the lumbar spine. So let's see if this spinal column here is of a normal curvature using those tables down below. So we can see for the neutral thoracic kyphosis, so this is for that normal curve of the thoracic spine, it should be between around 20 to 45 degrees, and I've got 38. So we'd say that this picture is normal when it comes to the thoracic curvature. And then for the lumbar, now lumbar we call this term lordosis. So for the neutral lordosis, for that neutral lumbar curve, we're looking for between 20 to 40 degrees. And what did we get? Right on 40. So right on the cusp of that neutral lumbar curve. If it was less than 20, we'd call this hypolordosis. So, and then if it was greater than 40, we'd call this hyperlordosis. So something to note when we have that hypo and hyper, hyper always means lower than, and hyper always means greater than. So if we think about like hypothermia means you're very cold, you're colder than normal, hypo. If you think about hyperthermia, that means you're hotter than normal. If we think about hypertension, that's someone with high blood pressure, high blood pressure. If you think about someone with hypotension, that means they've got low blood pressure. So that those terms should make it easy to remember these definitions. If you know the neutral, then you know above that is going to be the hyperlordosis or hyperkyphosis, whether we're talking about the thoracic or the lumbar spine there. Okay, awesome. Now, on this picture as well, we can actually draw the center of gravity. And the center of gravity is not something we've really spoken about too much. But have a look here at how we draw the center of gravity. So, oh, this is not it. Here we go. So let's have a look at the center of gravity here. So, the center of gravity actually intercepts at the fourth lumbar vertebrae. So if you find the fourth lumbar vertebrae and draw a dot in the middle of the body of the fourth lumbar vertebrae, the normal line of the center of gravity crosses ventral to the center of the fourth lumbar vertebrae body. So if you draw that dot right in the middle of the body of the fourth lumbar vertebrae, the center of gravity line should pass just anterior to that dot, and that's our normal center of gravity. Now, the amount of curvature we have at the spinal column can affect our center of gravity quite dramatically. So if you think about someone with hyperkyphosis, with that hunchback position, that's actually going to end up pushing that center of gravity forwards, like so. So you can see the neutral image here on the left-hand side with that red line intercepting just in front of the center of that fourth lumbar body. And then if we have this exaggerated curve, particularly of the thoracic here in this second picture, you can see just how far that center of gravity line has shifted forwards. So this is demonstrating a bad posture. So that hunched upper back or that hunched thoracic back. And then one of the typical signs of bad posture is when the head sticks forwards, like so, right? So you can see that there, the neutral head, nice and straight, and then that bad posture head really sticking forwards, and that center of gravity shifts forwards there as well. So you can have a go at drawing that in your lab books. But something else interesting to note on this image is that other angle that's coming from the pelvis there. So you can see in the black lines we've got another angle, and we can see in the normal picture the pelvis looks nice and straight. But then in the second picture showing us that bad posture, the pelvis looks like it's tilted forwards. And you might have heard this term before called anterior pelvic tilt. So that's what we're looking at here, is this bad posture with this anterior pelvic tilt here, which is sort of exaggerating that curve of the spine there. And you can see some images here of anterior and posterior pelvic tilt. Now, some people tend to get confused with these ones. A good way to think of it is if you take your pelvis, right, and you want to, if you think about it like a glass of water, and then you want to pour water out the front, you're going to anteriorly pelvic tilt your coxal bones and your sacrums to pour water out the front of your pelvis. And then if you do the posterior pelvic tilt, you're sort of tucking your butt under, you're going to pour water out the back. So good posture should be a nice level pelvis, anterior pelvic tilt, tilting that water out the front of the pelvis. You can do it sitting in your chair now. And then posterior pelvic tilt is the other way. Here's another image. It might help to visualize that. So the picture on the left, you're looking at an anterior pelvic tilt there. So you can see the butt sort of sticking out. And then the picture on the right showing the posterior pelvic tilt. So neutral pelvic tilt should be around a 30-degree angle at the sacrum. If it's a posterior pelvic tilt, it's going to be less than 30 degrees, and if it's an anterior pelvic tilt, the angle will be greater than 30 degrees. And you can see that more clearly the angle that I'm discussing at the bottom of your page. So there's our 3 different types of pelvic tilts there. Now, there's a lot of debate about the pelvic tilt. If most people have some sort of an anterior pelvic tilt, I believe. I think it's actually very common to have this anterior pelvic tilt. But it's nothing to worry about. It does perhaps increase the loads on the lumbar spine. So if you have really an excessive anterior pelvic tilt, you can increase that load on the lumbar spine, which isn't good for injuries. And when we have this really exaggerated lumbar lordosis, so if you have hyperlordosis of the lumbar spine, that's probably the main predictor, the main cause of lower back pain in adults. So it can be not good if you have it severe, but if you've just got a bit of an anterior pelvic tilt, it's nothing to worry about. It is something to worry about if you're doing lots of weightlifting, putting lots of load through the trunk. Then it's definitely something that you want to fix whilst you're doing that exercise. But day to day, it tends to not be too much of an issue unless it's super severe. Now, another interesting thing with pelvic tilt is when we talk about sprinting and running, because it's a big debate in that area. If you look at these 2 pictures, we're comparing an Olympic sprinter to a team sport athlete here. And you can see with those red lines, the Olympic sprinter, the pelvis seems to be much more level, whereas with the team sport athlete, the pelvis is tilted forward. It's tipping that water out the front there. Now, with sprinting, oftentimes, if you look up on Google, pelvic tilt for sprinting, you will find people on complete opposite sides to one another. Some people say that you need to have a neutral pelvis because that allows you to sort of produce more force through your feet as you're running and get up to that high sort of max velocity. But there's people on the internet who say the complete opposite and say, no, you want to have a bit of an anterior pelvic tilt so that you can extend the hip out the back. You can see in this picture as well with the team sport athlete, the hip is much more extended out the back than with the Olympic sprinter. So there's really two camps on this as well, but it's an interesting sort of debate. If you look at images from like the Olympics of the sprinters running, they tend to be more neutral, like in this image here. So you can see in a bit of analysis of the differences between the 2 runners here. So we can see that with the Olympic sprinter, the posture is more upright with that neutral pelvis, whereas with the non-sprinter or the team sport athlete, the chest is more forwards. You can see that banana shape in the back, which is that typical presentation of that anterior tilt of the pelvis. So interesting comparison here. Perhaps if we have a sprinter amongst us, you might be able to provide some insight onto this topic. All right, so we've spoken about how the curves of the spine and the anterior pelvic tilt influences the loads on the spinal column and also the center of gravity. But another important feature that influences our center of gravity is our muscles that play a role in this. So it's the erector spinae that are the muscles that have a big influence on postural control. And we saw previously in that person with the bad posture how the center of gravity is shifted forwards. Well, it's the erector spinae that have to sort of counterbalance this anterior sort of change in the center of gravity. The erector spinae have to contract and keep us upright so we don't just fall forwards, right? So they're very important muscles for posture as well as for extension of the trunk, as we know we're the agonist of trunk extension, but very important for posture as well. Okay, so the next question I want to ask you guys is to think about a position that we could get ourselves into that has the lowest amount of load on the lumbar spine. Now, you may have seen this diagram before. So we're looking at a whole heap of different positions and the loads that has on our spinal column. And you can see here the different positions represented by those different little drawings. And then the two columns, so the white column and the blue column, just represent two different articles or studies that have sort of analyzed this. So don't worry about the differences between the two columns. That just means this is one research group findings, and then there's the other research group findings. So just take the average of the two when you're looking at them when they're different. So this diagram shows us the loads on the spine in different positions. So we can see it's pretty low when we're lying on our side with the arm raised. That's the first image there. We can see it's very high when we're holding that object, standing with our legs straight and our back curved, holding that object away from the body. We can see that if we pick up this object in a better position by bending the knees, that reduces the load on the spine. Still, it's very high, but it reduces it from what it may have been if we didn't keep our back flat. But there's a position that gets pretty much all the way down to zero that's not shown on this diagram. Now, when we're in class, sometimes I'll get you guys into groups and try and think of that position together. So if you can now in your head, try and think of a position, and it's not being in outer space. There's always someone every year who says, is it being in outer space? No, it's not. I'm not trying to trick you with this question. There is a real position, and I'll give you a hint. So hopefully you've got something in your head, but the hint is it has to do with this muscle right here, our iliopsoas muscle. So a big hip flexor muscle here, and you can see that it's connecting, or it's originating from the lumbar spine as well as the coxal bone and inserting down into the femur. Now, if it is originating from the lumbar spine, if this muscle is stretched, it's going to pull a little bit on that lumbar spine, and by that pulling, it's going to increase the loads on the spine. So hopefully you're thinking of a position. Most people probably thinking of, lying down on their back with a pillow underneath, the curve of their spine. That's a common one people suggest. Let's have a look at this next drawing I have done. So if we draw someone lying down on their back, right? So we're going to draw a little head here. There's the body, there's the feet at the end. Now when you're lying down straight, we can pretend there's a pillow underneath the curve of the back. What happens is this iliopsoas muscle, if I draw it on with pink here so you can see it clearly, it is being stretched. So the iliopsoas muscle is actually stretched in that position. And if that muscle is stretched, it's going to be pulling slightly on that lumbar vertebrae, which is going to have some sort of influence or some sort of impact on the load of the lumbar spine. So lying flat on the back is not the answer, or even with a pillow underneath your back. This is not the answer, because we have an increased load on the lumbar spine, because that's where this muscle is originating from, and it's being stretched in this straight position. So the answer is lying down on your back with your hips and knees elevated, so they're both at a 90-degree angle. So in this position, it actually completely reduces any pulling of that iliopsoas muscles on the lumbar vertebrae. So in this position here, the muscle is shortened, so it's not pulling, it's completely relaxed. So there's no tension on the lumbar vertebrae to increase that load at all. So this would be our correct answer for which position decreases or reduces the loads on the lumbar spine the most. Awesome. All right, so we have come to the end of the content. Now we're up to our last station, looking at a movement analysis. So we're going to be looking at the tennis serve today. I am going to hit play on the tennis serve, and I want you to have a go at completing this one. So I'll give you guys 4 minutes to have a go at it. My hint for this one is that there's more than one action happening at the glenohumeral joint during each phase. So during phase 1, phase 2, and phase 3 for the glenohumeral joint, there's actually more than one thing happening. Now, this might be the first case that you've come across this. When there's more than one thing happening, we just want to follow that through. Just pretend there's almost 2 lines at the glenohumeral joint. So you're going to have 2 different muscle groups and then 2 different sets of agonists as well if we've got 2 different actions happening at that joint. So have a go at this. We'll come back and talk through the answers in a moment. Alright guys, so let's talk through this. Now I know this is one of the harder ones that we've done, particularly because it includes the glenohumeral joint, but let's talk through these answers and see how we went. So there's a few things going on here. Now, if we look firstly at the contraction type column, hopefully you all got the contraction types as a minimum. So in phase 1, again, we're lifting the arm up or we're producing that acceleration. So it's going to be concentric, both at the glenohumeral and the elbow joint. In phase 2, now we're really producing that acceleration as we go to hit the ball. So we've lifted the arm up in phase 1. Now we're really trying to produce force and hit that ball. So again, it's going to be a concentric contraction. And then in phase 3, once that ball leaves that racket, it becomes eccentric because the message is sent that, okay, I don't need to accelerate anymore. Let's get this arm to slow down so that I don't end up whacking myself in the face. So it's going to be an eccentric contraction in phase number 3. Now let's talk about the joint actions. So at the glenohumeral joint in phase 1, the arm is abducting and externally rotating. So you had to have both of those actions there to get this right. For the elbow, it was flexing during phase 1. For phase 2, the glenohumeral joint is now horizontally adducting and internally rotating at the same time. Okay, if you said flexion rather than horizontal rotation, I'll give you that mark as well. So that grey just means it's also correct, but not necessarily the one I would have chosen. So for phase 2, you should have had horizontal adduction and internal rotation, or flexion and internal rotation. And then in phase 2, the elbow goes from bent to straight, so it is extending. So the joint action there being extension. Now in phase 3, which is the final phase, it's the sort of recovery phase, I guess, or follow-through phase. The glenohumeral joint is horizontally adducting and internally rotating as well. So it continues that same motion. Once the ball leaves the racket, in phase 3, it continues doing the same thing. Now, again, if you said flexion and internal rotation, I'll give you the correct mark there too. Or you could have even said adduction and internal rotation for the correct mark. I would have given that to you too, because I can see how you could interpret this sort of differently. And then for the elbow, it would be flexion. Then for the muscle group and the agonist, you should have just followed that through. We've learned how to do that very well by now. So hopefully the muscle group and the agonist column is making sense to you and is becoming just automatic now. If it's concentric, remember the muscle group is the same as the joint action. And if it's an eccentric contraction, the muscle group is the opposite of the joint action. And then always remember that the agonists are the agonist of the muscle group, not the agonist of the action. So then we can fill in our agonist column as well. So I hope you guys found that all right. Any questions, you're welcome to email me, but hopefully I'll see you in class this week.